I'm going to tell you something that might surprise you. In my clinic, I see men in their 70s who walk in with erections that would make a 30-year-old jealous, and I see men in their early 50s who can barely achieve anything firm enough for penetration. The difference between these two groups is rarely just age. It's a constellation of choices, habits, and risk factors that accumulate over decades. And the good news is that most of them are modifiable. My name is Dr. William Carter. I'm a board-certified urologist with over 25 years specializing in men's sexual health, erectile dysfunction, and the intersection of sexual medicine and cardiovascular risk. I've spent my career helping men understand that erectile quality is not a dice roll determined by your birthday. It's a window into your overall vascular health, and when you optimize the systems that drive blood flow, nerve signaling, and hormonal balance, you protect not just your sexual function but your heart, your brain, and your longevity. Before we go further, hit subscribe and drop your number one concern in the comments: rigidity, staying power, or performance anxiety. I read everything and answer the most liked questions in upcoming videos. And please share this with a friend who needs straight, stigma-free answers. Let me start with a patient I'll call Robert. He came to see me at 56. He'd been noticing that his erections weren't as reliable as they used to be. Sometimes they'd start strong and then fade halfway through. Other times he couldn't get firm enough to penetrate. He was frustrated, embarrassed, and convinced it was over for him. When I asked about his health, he admitted he'd gained 30 pounds since his 40s. His blood pressure was creeping up, he was pre-diabetic, he hadn't exercised consistently in years, and he was drinking 3 or 4 beers most nights to unwind. His relationship with his wife was good, but the bedroom failures were creating distance. Robert thought his problem was psychological. He thought he just needed to relax. But when we ran labs and looked at his vascular risk profile, it was clear his end wall, the inner lining of his blood vessels, was struggling. His erection problem wasn't in his head, it was in his arteries. Now, let's talk about what an erection actually is. Because once you understand the mechanics, everything else makes sense. An erection is a vascular event. It requires healthy arteries, healthy nerves, and a finely tuned interplay of chemical signals. When you become aroused, whether from physical touch, visual stimuli, or fantasy, your brain sends signals down the spinal cord to the nerves in your pelvis. Those nerves release a molecule called nitric oxide into the smooth muscle cells that line the walls of the arteries inside your penis. Nitric oxide triggers a cascade that causes those smooth muscles to relax. When the smooth muscle relaxes, the arteries dilate, and blood rushes into the spongy erectile tissue, the corpora cavernosa. As the tissue fills with blood, it expands and compresses the veins that normally drain blood away. This traps the blood inside, creating the pressure that gives you a firm, rigid erection. That's the simplified version. The key players are end wall function, which is the health of that inner arterial lining, nitric oxide production, smooth muscle responsiveness, adequate arterial inflow, and effective venous trapping. If any part of that chain breaks down, your erection suffers. Here's why this matters beyond the bedroom. Your penis is a vascular organ, and the arteries that supply it are smaller than the arteries that supply your heart. That means erectile dysfunction is often an early warning sign of systemic vascular disease. Studies have shown that a man with ED has a significantly higher risk of having a heart attack or stroke in the next few years, even if he has no chest pain or other cardiac symptoms. ED is a red flag. It's your body telling you that your end walls is damaged. That atherosclerosis, the buildup of plaque in your arteries, is starting to choke off blood flow. When I diagnose a man with ED, I'm not just thinking about his sex life, I'm thinking about his cardiovascular risk, and I often send him to cardiology for a full workup. Protecting your erections means protecting your heart, and vice versa. So why do some men keep strong erections well into their 70s and 80s, while others struggle in their 50s? The men who maintain erectile quality tend to share a handful of characteristics. They've kept their weight in a healthy range throughout adulthood, they don't smoke, or they quit decades ago, they exercise regularly, a mix of aerobic activity and some form of resistance training, they eat a diet rich in vegetables, fruits, whole grains, healthy fats like olive oil and omega-3s from fish, and they limit processed junk. Their blood pressure is controlled, their cholesterol and triglycerides are in healthy ranges, their blood sugar is stable, no diabetes or prediabetes, they sleep well, 7 to 9 hours most nights, and if they have sleep apnea, they treat it. They manage stress reasonably well. They drink alcohol in moderation, if at all. They maintain strong intimate relationships, and they communicate openly with their partners about sex. They don't fall into shame spirals when things don't go perfectly. These men didn't do anything magical, they just avoided or mitigated the major risk factors that destroy end wall function and nitric oxide signaling. Let me explain what wrecks erections. Because understanding the enemy is half the battle. Hypertension, high blood pressure, damages the endothelin over time. The constant high pressure injures the delicate inner lining of your arteries, promoting inflammation and plaque buildup. That reduces nitric oxide availability and stiffens the arterial walls. Atherosclerosis, the accumulation of fatty plaques in your arteries, narrows the channels through which blood flows. When the arteries feeding your penis are narrowed, you can't get the inflow you need for a rigid erection. Diabetes and prediabetes wreak havoc on both the blood vessels and the nerves. High blood sugar damages in Walhay cells, reduces nitric oxide production, and causes microvascular disease. It also damages the nerves that signal the smooth muscle to relax. Men with diabetes are 2 to 3 times more likely to have ED, and it often shows up earlier and is more severe. Dyslipidemia, abnormal cholesterol and triglycerides, contributes to plaque formation. High LDL cholesterol and low dull cholesterol accelerate atherosclerosis. Obesity, especially central adiposity, that belly fat, is an independent risk factor. Visceral fat is metabolically active. It pumps out inflammatory cytokines and disrupts hormone balance. It lowers testosterone and increases estrogen through aromatization. It promotes insulin resistance. All of this interferes with nitric oxide signaling and vascular health. Smoking is one of the worst things you can do for your erections. Nicotine constricts blood vessels acutely, and the chronic exposure damages in Walhay function, accelerates atherosclerosis, and reduces oxygen delivery. Alcohol in excess is a central nervous system depressant. It impairs arousal, blunts nerve signaling, and over time contributes to vascular damage and hormonal imbalances. A sedentary lifestyle means your endothelin doesn't get the regular stimulus it needs to produce nitric oxide and adapt. Exercise is a powerful trigger for vascular remodeling and Walhay health. Without it, your blood vessels become sluggish. Then there are the less obvious culprits. Sleep apnea, where you stop breathing repeatedly during the night, causes intermittent hypoxia, drops in oxygen which triggers oxidative stress and inflammation. It also raises blood pressure and disrupts sleep architecture, all of which harm erectile function. Depression and anxiety interfere with arousal and desire. Antidepressants, particularly Skris, can blunt libido and impair erectile function and orgasm. The stress response itself, chronic activation of the sympathetic nervous system, elevates cortisol and adrenaline, which constrict blood vessels and divert blood away from the pelvis. Performance anxiety creates a vicious cycle. You worry about failing, the worry activates the stress response impairs your erection. The failed attempt reinforces the anxiety. Some men develop what I call a pornography-driven performance loop. They've conditioned themselves to a very specific, high-intensity visual stimulus, and when they're with a partner, real intimacy doesn't provide the same dopamine spike. This can lead to arousal issues and a disconnect between mental desire and physical response. Pelvic floor dysfunction is underapriostatic. Some men chronically over-recruit their pelvic floor muscles, essentially gripping them too tight, which can impede blood flow and create pain. Others have weak or uncoordinated pelvic floor muscles that can assist with venous trapping. Certain medications can impair erections. Some blood pressure medications, especially older beta blockers and thiazide diuretics, can interfere with erectile function. Though newer agents are often better tolerated, finasteride and dutasteride, used for hair loss or prostate enlargement, can cause sexual side effects in a subset of men. Antihistamines, some antipsychotics, and opioids can also contribute. Prostate issues and benign prostatic hyperplasia, finasteride, often go hand in hand with ED, especially in older men. When you have lower urinary tract symptoms, frequent urination, urgency, weak stream, nocturia, getting up multiple times at night to pee, it disrupts your sleep. Poor sleep impairs testosterone production, which happens primarily during deep sleep. Chronic pelvic congestion and inflammation from an enlarged prostate can contribute to pelvic discomfort and reduce sensation. The psychological burden of constantly thinking about your bladder and worrying about urinary control can interfere with sexual focus. Plus, some of the medications used for finasteride, like alpha blockers, can occasionally cause retrograde ejaculation or contribute to it, though newer selective alpha blockers are usually well tolerated. Now let's talk about what you can do. The foundation is lifestyle. And I know that sounds boring and obvious, but the data is overwhelming. Exercise is one of the most powerful interventions for erectile function. Aerobic exercise, walking, jogging, cycling, swimming, improves Walhay function by increasing shear stress on the arterial walls, which stimulates nitric oxide production. It promotes angiogenesis, the formation of new small blood vessels. It lowers blood pressure, improves insulin sensitivity, raises adult cholesterol, reduces inflammation, helps with weight control, and boosts mood. Resistance training, lifting weights, bodyweight exercises, helps build muscle mass, which improves metabolic health and supports testosterone production. The sweet spot for most men is at least 150 minutes of moderate intensity aerobic activity per week. That's 30 minutes 5 days a week, plus 2 days of resistance training. If you're starting from zero, begin with 10 or 15 minutes of walking daily and gradually build. Consistency beats intensity. The goal is to make movement a non-negotiable part of your routine. Nutrition matters enormously. You don't need a complicated diet. A Mediterranean-style pattern is the gold standard. That means plenty of vegetables, fruits, whole grains, legumes, nuts, seeds, olive oil as your primary fat, fish 2 or 3 times a week for omega-3s. Moderate amounts of poultry, occasional red meat, minimal processed foods, and limited added sugar. This pattern is anti-inflammatory, supports healthy lipid profiles, provides antioxidants and polyphenols that protect end-wall function, and helps with weight management. Think of your plate as half vegetables, a quarter lean protein, and a quarter whole grains or starchy vegetables. Snack on nuts, fruit, or yogurt instead of chips and cookies. Fiber is crucial. It helps regulate blood sugar, supports gut health, and binds cholesterol. Omega-3s from fatty fish like salmon, mackerel, sardines, and from walnuts and flax seeds reduce inflammation and support vascular health. Polyphenols, found in berries, dark chocolate, green tea, and red wine in moderation, have been shown to improve end-wall function. Limit trans fats and excessive saturated fat, which promote atherosclerosis. Cut back on ultra-processed foods, which are loaded with sugar, unhealthy fats, and sodium. Weight loss, if you're overweight, can have a dramatic impact on erectile function. Losing even 5 to 10% of your body weight can improve blood pressure, blood sugar, cholesterol, and testosterone levels. Visceral fat, that deep belly fat, is particularly harmful because it secretes inflammatory molecules and disrupts hormone balance. As you lose visceral fat, your testosterone often rises and your estrogen drops, both of which support better erections. Set realistic goals. A pound or 2 a week is sustainable. Crash diets don't work long-term. Focus on building habits, not perfection. Sleep is non-negotiable. Aim for 7 to 9 hours per night. Testosterone is produced during deep sleep, and chronic sleep deprivation tanks your levels. Poor sleep also increases cortisol, promotes weight gain, impairs insulin sensitivity, and worsens mood. If you snore loudly, gasp for air at night, or wake up feeling unrefreshed despite spending enough time in bed, get evaluated for sleep apnea. Continuous positive airway pressure, PAP, or other treatments can be life-changing. Maintain a consistent sleep schedule. Keep your bedroom cool, dark, and quiet. Limit screen time before bed. Avoid heavy meals, caffeine, and alcohol close to bedtime. Stress management is critical. Chronic stress activates the sympathetic nervous system and elevates cortisol, both of which constrict blood vessels and divert blood flow away from non-essential functions like erections. Find practices that help you down-regulate. Deep breathing exercises. Box breathing, 4 seconds in, 4 seconds hold, 4 seconds out, 4 seconds hold, can shift you into a parasympathetic state. Heart rate variability training, using apps or biofeedback devices, can help you build resilience. Regular physical activity is itself a stress buffer. Mindfulness meditation, even just 10 minutes a day, can reduce anxiety and improve emotional regulation. Reframe performance anxiety. Sex is not a test, it's an experience. If you go into an encounter worried about failing, you've already activated the stress response. Instead, focus on pleasure, connection, and exploration. Communicate with your partner. Talk about what feels good, what doesn't, what you need. Most partners are far more understanding and supportive than you imagine. Alcohol and smoking. Let's be clear. Moderate alcohol, that's up to 2 drinks a day for men, may not significantly harm erectile function, and some studies even suggest a J-shaped curve where light drinking might have a slight protective effect on cardiovascular health. But heavy drinking, more than 2 drinks a day, is associated with worse erectile function, hormonal imbalances, and vascular damage. If you're struggling with ED, cutting back or eliminating alcohol is worth trying. Smoking is unequivocal. If you smoke, quitting is one of the best things you can do for your erections and your overall health. Within weeks to months of quitting, end-wall function begins to improve. Within a few years, your cardiovascular risk drops significantly. Pelvic floor health is an underappreciated piece of the puzzle. Your pelvic floor muscles support your bladder and bowel, and they play a role in erectile function and ejaculation. Some men chronically over-recruit these muscles, essentially holding tension in the pelvis, which can impede blood flow and cause pain or discomfort. Others have weak or uncoordinated pelvic floors that can effectively assist with venous trapping or ejaculatory control. If you have pelvic pain, difficulty urinating, or a sense of incomplete emptying, or if you feel like you're constantly tensing your pelvic floor, you may benefit from pelvic floor physical therapy. A specialized pelvic PT can assess your muscle coordination and teach you relaxation techniques or, if needed, strengthening exercises. For many men, learning to relax the pelvic floor is more important than strengthening it. Kegel exercises, the classic squeeze and hold, can be helpful for some men, but done incorrectly or excessively, they can worsen problems. Work with a professional if you're unsure. Now let's talk medical optimization. Before we discuss treatments, we need data. If you're experiencing erectile dysfunction, you should have a comprehensive evaluation. That starts with a detailed history and physical exam. Your doctor should ask about the onset, severity, and pattern of your symptoms. Are you able to achieve any rigidity, or is it completely absent? Do you wake up with morning erections, or have they disappeared? Can you get erect with masturbation but not with a partner? These questions help differentiate between organic causes, like vascular or hormonal, and psychogenic causes, like anxiety. Your doctor should review your medical history, medications, surgical history, and lifestyle factors. Labs are essential at a minimum. You should have your blood pressure checked, fasting glucose or hemoglobin A1C to assess for diabetes or prediabetes, and a fasting lipid panel to evaluate your cholesterol and triglycerides. Testosterone should be measured, ideally in the morning when levels are highest. Total testosterone is a good starting point, but if it's borderline, or you have symptoms despite a normal total level, free testosterone or bioavailable testosterone gives a more accurate picture of what's actually active in your body. Some clinicians also check sex hormone binding globulin, SHBG, which binds testosterone and affects how much is free. Thyroid function, SHI and free FAR, should be checked because hypothyroidism can contribute to low libido and erectile dysfunction. Prolactin, a hormone produced by the pituitary gland, should be measured if testosterone is low or if you have symptoms like low libido or breast tissue development. Because elevated prolactin can suppress testosterone and cause it. If there are red flags, like chest pain with exertion, significant dyspnea, or abnormal cardiac findings, a referral to cardiology is warranted. An ECG, stress test, or echocardiogram might be needed. Interpreting results. If your blood pressure is elevated, it needs to be controlled. If your glucose or A1C is in the diabetic or prediabetic range, addressing that is a priority. If your lipids are abnormal, lifestyle changes and possibly medication are indicated. If your testosterone is low, we need to investigate why. Is it primary hypogonadism, a problem with the testicles, or secondary hypogonadism, a problem with the pituitary or hypothyroidism? Is it due to obesity, sleep deprivation, chronic illness, or medications? Treating the underlying cause is the first step. Let's talk about the therapeutic ladder. We start with the least invasive, most widely applicable options, and move up if needed. The first line is almost always a D5 inhibitor. These are the medications you've heard of. Sildenafil, sold as Viagra, tadalafil, sold as Cialis, Vardenafil, sold as Levitra, Evenlafil, sold as Stendra. They all work by the same basic mechanism. They inhibit an enzyme called phosphodiesterase type 5, which normally breaks down cyclic GPM, the molecule that keeps the smooth muscle in your penis relaxed and the arteries dilated. By blocking that enzyme, D5 inhibitors amplify the effect of nitric oxide and help you achieve and maintain an erection in response to sexual stimulation. Key point, they do not create an erection on their own. You still need arousal and stimulation. They just make the process more reliable. Sildenafil typically kicks in within 30 to 60 minutes, lasts 4 to 6 hours, and is best taken on an empty stomach because a heavy, fatty meal can delay absorption. Tadalafil takes about an hour to kick in, but it lasts up to 36 hours, which is why it's often called the weekend pill. It's less affected by food. Vardenafil is similar to sildenafil in onset and duration. Evenlafil is the newest and has a faster onset, often within 15 to 30 minutes. The choice depends on your lifestyle and preferences. If you want spontaneity over a longer window, tadalafil is great. If you want something that works quickly and clears out faster, sildenafil or Evenlafil might be better. Daily low-dose tadalafil, usually 2.5 or 5 milligrams once a day, is an option for men who want to be ready anytime without planning. It maintains a steady level in your system, and some studies suggest it may have additional benefits for Ndwalhe health and even lower urinary tract symptoms from FNACETER. It's more expensive than on-demand dosing, but many men find the spontaneity worth it. D5 inhibitors are safe for most men, But there are absolute contraindications. If you take nitrates for chest pain, like nitroglycerin, isosorbide mononitrate, or isosorbide dinitrate, you cannot use DEF inhibitors. The combination can cause a dangerous drop in blood pressure. If you use recreational poppers, which contain nitrites, same issue. If you have severe cardiovascular disease, uncontrolled hypertension, or recent stroke or heart attack, your doctor needs to clear you before you use these medications. Side effects are generally mild and include headache, flushing, nasal congestion, and indigestion. A small percentage of men experience visual disturbances, a blue tinge to vision. Especially with Silden Way, these side effects usually diminish with continued use, if DEF inhibitors don't work well enough, or if you can't tolerate them. The next step is often a vacuum erection device, VED. This is a plastic cylinder that you place over your penis. You pump out the air, creating negative pressure that draws blood into the erectile tissue. Once you achieve an erection, you slide a tension ring off the base of the cylinder onto the base of your penis to trap the blood. The ring can stay on for up to 30 minutes. VEDs are safe, non-invasive, and can be used in combination with DEF inhibitors for men who need a little extra help. The downsides are that it's a bit mechanical, it takes practice to use smoothly, and the erection may feel cooler or less natural because venous blood is trapped. Some men experience bruising if they pump too aggressively or leave the ring on too long, but for many men, especially those who can't use medications, VEDs are a game changer. If DEF inhibitors and vacuum devices don't provide adequate results, we move to more invasive options. Topical or intrawear alprazolatol is one approach. Alprazolatol is a synthetic form of prostaglandin, which directly relaxes smooth muscle and dilates blood vessels. A topical formulation can be applied to the head of the penis, or a small pellet can be inserted into the urethra using an applicator. The medication is absorbed and helps generate an erection. It's not as effective as injections, and some men experience urethral burning or discomfort, but it's an option for those who are needle-averse. Intracaverous injection therapy is highly effective. This involves injecting medication directly into the side of the penis, into the corpus cavernosum. The most common agent is alprazolatol, but many men use combination medications like Bimix, a blend of papaverine and phentylamine, or Tremix, which adds alprazolatol to the Bimix. These medications work locally to relax smooth muscle and increase blood flow. The erection usually develops within 5 to 20 minutes and lasts 30 to 60 minutes, sometimes longer. The injection itself is done with a very fine needle, similar to an insulin syringe. And most men find it far less painful than they expect. The key is proper training. Your urologist or a trained nurse will teach you the technique, how to identify the injection site, how to avoid the urethra and the dorsal vessels, how to dose correctly. The most important safety concern is priapism, an erection that lasts more than 4 hours, which can damage the erectile tissue if not treated promptly. This is rare if you're dosed correctly, but if it happens, you need to go to the emergency room immediately for treatment, which usually involves aspirating the blood and sometimes injecting a medication to constrict the vessels. Some men develop scarring or curvature over time with repeated injections, but this is uncommon if you rotate injection sites and use proper technique. Intracaverous therapy is often combined with a VED or used when DEF inhibitors have failed. Testosterone therapy is indicated only if you have confirmed hypogonadism, meaning low testosterone levels documented on at least 2 separate morning measurements, along with symptoms like low libido, fatigue, decreased muscle mass, and erectile dysfunction. Testosterone is not a cure for ED if your levels are normal. It's not a magic bullet, but if you have true hypogonadism, replacing testosterone can improve libido, energy, mood, and often erectile function, especially if the ED is partly due to low desire or arousal. Testosterone comes in multiple formulations, topical gels or creams, which you apply daily to your shoulders or abdomen, intramuscular injections, typically every 1 to 2 weeks or sometimes longer with newer formulations. Subcutaneous pellets, which are implanted under the skin and release testosterone over several months. Nasal gels, oral testosterone is now available in a newer formulation, though older oral forms were problematic for the liver. Each has pros and cons. Gels are convenient but can transfer to partners or children through skin contact, so you have to be careful. Injections are effective, but can cause fluctuations in levels, leading to mood or energy swings. Pellets are convenient, but require a minor procedure every few months. Risks of testosterone therapy include increased red blood cell production, which can thicken the blood and raise the risk of clots, so you need regular monitoring with complete blood counts. It can worsen sleep apnea, so untreated sleep apnea should be addressed first. It can stimulate prostate growth and potentially unmask prostate cancer, though it doesn't cause prostate cancer. so you need baseline and periodic SAW testing and digital rectal exams. It can reduce sperm production and harm fertility, so if you're hoping to father children, testosterone therapy is typically not appropriate unless you're also using medications to preserve fertility or banking sperm. It can cause acne, fluid retention, and mood changes. Some men also experience testicular shrinkage because the testicles stop producing their own testosterone when you're supplementing. These risks need to be weighed against the benefits. For many men with true hypogonadism, the improvement in quality of life is profound. Shockwave therapy, specifically low-intensity shockwave therapy, LIST, has gained attention in recent years. The idea is that acoustic waves applied to the penis stimulate angiogenesis and improve blood flow. Some studies suggest modest improvements in erectile function, especially in men with mild to moderate vascular ed, who respond partially to DEFIV inhibitors. The treatment typically involves multiple sessions over several weeks, and it's painless. However, the evidence is still evolving, the protocols vary widely, the devices used are not standardized, and long-term data is limited. Some men see improvement, others see none. It's not DME approved in the United States for ED, though it's available off-label in many clinics. If you're considering shockwave therapy, ask your provider about the specific device, the evidence for that protocol, and realistic expectations. It's not a miracle cure, but it may be a reasonable option for men who want to avoid medications or who are looking to improve their baseline function. When all else fails, or when a man simply wants a permanent, reliable solution, a penile implant is the gold standard. This is a surgical procedure where inflatable or malleable rods are implanted into the corpora cavernosa. The most common type is the 3-piece inflatable prosthesis, which consists of 2 cylinders placed in the penis, a reservoir of saline implanted in the abdomen, and a pump placed in the scrotum. When you want an erection, you squeeze the pump, which transfers saline from the reservoir into the cylinders, inflating them and creating a rigid erection. When you're done, you press a release valve, and the saline drains back into the reservoir. The 2-piece inflatable is simpler but may not give quite as natural a feel. Malleable or semi-rigid implants are the simplest, bendable rods that you position as needed. They're always semi-rigid, which some men find less natural but others find convenient. Penile implant surgery is typically an outpatient procedure done under anesthesia. Recovery takes about 4 to 6 weeks before you can resume sexual activity. Satisfaction rates are very high, often over 90% for both men and partners, because the device provides reliable, on-demand rigidity. However, it's irreversible. Once you have an implant, the natural erectile tissue is permanently altered, so you can't go back to relying on your native erections. Risks include infection, mechanical failure, erosion of the device through the skin, and rarely, problems with the pump or tubing. Modern devices are very reliable, but any mechanical device can eventually fail and may require replacement. Despite these considerations, for men who have exhausted other options or who have conditions like severe diabetes or post-prostatectomy ED where other treatments don't work, implants are life-changing. Couples counseling or sex therapy before and after implant surgery can help partners adjust to the change and maintain intimacy during the healing period. Psychosocial factors are crucial, and they're often intertwined with the physical issues. Many men enter a cycle where a physical problem, vascular, hormonal, or neurologic, causes an erection failure. The failure triggers anxiety, the anxiety worsens the physical response, leading to more failures, and the cycle reinforces itself. Breaking that cycle requires addressing both the physical and the psychological. Sensate focus exercises, a technique from sex therapy, can help. The idea is to take the pressure off performance by temporarily removing intercourse from the table. You and your partner engage in non-genital touch, then progress to genital touch without the goal of erection or orgasm, and eventually reintroduce penetration only when both partners feel ready. This reduces performance anxiety and helps you reconnect with pleasure rather than focusing on the outcome. Communication is everything. Many men suffer in silence, afraid to talk to their partners about their struggles. But most partners are far more concerned about the emotional distance and lack of communication than they are about the erection itself. Have an honest conversation, explain what you're experiencing, ask what your partner needs, redefine success. An intimate encounter doesn't have to end with penetration to be satisfying. Explore other forms of pleasure, oral sex, manual stimulation, toys, whatever feels good for both of you. This takes the pressure off your penis as the sole source of pleasure and opens up new avenues for connection. Many men find that once they relax and expand their definition of sex, their erections actually improve because they're not stuck in their own head. If performance anxiety is severe, or if there are underlying issues like depression, trauma, or relationship conflict, working with a therapist or sex therapist can be incredibly valuable. Cognitive behavioral therapy can help reframe negative thought patterns. Mindfulness-based approaches can reduce anxiety and improve presence during intimacy. Couples therapy can address communication breakdowns and underlying resentments that may be manifesting in the bedroom. Let's briefly touch on the prostate and lower urinary tract symptoms, because this is relevant for many men over 50. Benign prostatic hyperplasia, FNCEDR, is a non-cancerous enlargement of the prostate that happens with age. As the prostate grows, it can compress the urethra and cause symptoms like frequent urination, urgency, weak stream, difficulty starting, and nocturia. Having to get up multiple times at night to pee. Nocturia is particularly disruptive because it fragments your sleep, reducing the amount of deep sleep you get, which is when testosterone is produced. Chronic sleep deprivation from nocturia can contribute to low testosterone, fatigue, and worsened erectile function. Additionally, chronic pelvic congestion and inflammation associated with FNCEDR may contribute to pelvic discomfort and reduced penile sensation. Managing FNCEDR symptoms can indirectly improve ED. Limit fluid intake a couple of hours before bed. Avoid caffeine and alcohol in the evening, both of which are bladder irritants and diuretics. Practice double voiding, urinating, waiting a moment, then trying to urinate again to fully empty the bladder. Avoid holding your urine for long periods. Take short walks during the day to promote pelvic circulation and reduce congestion. Medications for FNCEDR include alpha blockers, which relax the smooth muscle in the prostate and bladder neck, improving urine flow. And 5-alpha reductase inhibitors like finasteride and dutasteride, which shrink the prostate over time by blocking the conversion of testosterone to dihydroestradiol. Newer medications like tadalafil, the same DEFIV inhibitor used for ED, are DME approved for FNCEDR symptoms and can address both issues simultaneously. In severe cases, minimally invasive procedures or surgery may be needed to relieve obstruction. Now let me give you a practical 4-week starter plan, a roadmap for how to begin making changes. This is narrative, not a checklist, but it's a structure you can follow. Week 1, your focus is assessment and foundation. Get your labs drawn. Start tracking your symptoms. How often are you experiencing ED? How firm are your erections on a scale of 1 to 10? Are you waking up with morning erections? Begin moving your body. If you haven't been exercising, start with 15 minutes of walking every day. Don't overcomplicate it. Just walk. Look at your diet. Start adding 1 extra serving of vegetables per day, and swap out 1 processed snack for a handful of nuts or a piece of fruit. If you're a smoker, set a quit date and talk to your doctor about cessation aids. If you drink heavily, start cutting back. Aim for no more than 2 drinks a day, and have at least 2 alcohol-free days per week. Begin a basic sleep hygiene routine. Go to bed and wake up at the same time every day. Even on weekends, make your bedroom cool and dark. Week 2, build on the momentum. Increase your walking to 20 or 30 minutes most days. Add 1 session of resistance training, even if it's just bodyweight squats, push-ups, and planks at home. Continue adding more vegetables and whole foods. Try to have fish twice this week. Start a simple stress management practice, 5 minutes of deep breathing before bed or in the morning. If your labs come back and show issues, schedule a follow-up with your doctor to discuss next steps. If you haven't already, talk to your partner about what you're experiencing and what you're working on. If you've been prescribed a DFIV inhibitor, now is the time to try it. Start with the recommended dose on an empty stomach, give it enough time to work, and engage in foreplay and stimulation. Don't expect perfection the first time. It can take a few attempts to figure out the right dose and timing. Week 3, keep progressing. You're now exercising regularly, at least 30 minutes 5 days a week. Add a second resistance session. Your diet is improving. You're eating more plants, good fats, and lean protein, and less junk. You're sleeping better. Your stress practices are becoming a habit. If the DFIV inhibitor worked, great. If it didn't work as well as you'd hoped, talk to your doctor about adjusting the dose or trying a different medication. If you notice some improvement but not enough, consider adding a vacuum erection device to your routine. Practice using it at home so you're comfortable. If you haven't addressed pelvic floor tension, start noticing whether you're clenching your pelvic muscles during the day or during sex. Practice consciously relaxing them. If you have access to a pelvic floor PT, schedule a visit. Week 4, you're establishing new habits. Your exercise routine is solid. Your nutrition is better. You're managing stress. You're sleeping more consistently. If you've lost a few pounds, you might notice improvements in energy and mood. Your testosterone, if it was low, may start to rise with better sleep and weight loss, your erectile function may be improving, or at least you're seeing more frequent morning erections, which is a good sign of vascular health. If you're using a DF5 inhibitor or VED, you're getting the hang of it, you're communicating more openly with your partner, you're redefining what successful intimacy looks like, you're no longer spiraling into shame when things don't go perfectly by the end of week 4. You have data, you have a treatment plan, and you have a foundation of healthy habits. Let's talk timelines and realistic expectations, because this is important. If you start a DF5 inhibitor, you should see results within the first few uses, assuming the dose is right and you're using it correctly. If you start lifestyle changes, weight loss, exercise, diet, sleep, you won't see dramatic changes overnight. It takes weeks to months for vascular remodeling, improved end-wall function, and metabolic shifts to occur. At 2 weeks, you might notice better energy and mood. At 4 weeks, you may see small improvements in morning erections or rigidity. At 8 weeks, if you've been consistent, you should see more significant changes. Your weight is down, your blood pressure is better, your labs are improving, and your erectile function is more reliable. At 12 weeks, the cumulative effect of your efforts becomes clear. Many men find that by 3 months of consistent lifestyle change plus appropriate medical treatment, they've regained much of the function they lost. That said, not everyone responds the same way. Men with severe vascular disease, long-standing diabetes, or extensive nerve damage may have a ceiling on how much improvement they can achieve. That's okay, the goal is to optimize what's possible, and to use the therapeutic ladder to get you to a level of function that allows for satisfying intimacy. If oral medications and lifestyle changes don't get you there, that's when injections, devices, or implants come into play. This is not failure, this is problem solving. Follow-up is essential. If you start treatment and it's not working, don't suffer in silence. Call your doctor. Maybe the dose needs adjusting, maybe you need a different medication, maybe there's a comorbidite that wasn't addressed. If your erectile function plateaus or worsens despite treatment, that can be a signal that your cardiovascular disease is progressing. And it warrants further workup. Medicine is iterative. We adjust, we troubleshoot, we escalate when needed. Know when to seek care urgently. If you develop chest pain or severe shortness of breath during sexual activity, stop immediately and get emergency help. That could be a sign of cardiac ischemia. If you have a prolonged erection lasting more than 4 hours, go to the emergency room. This is priapism, and it's a medical emergency. If you suddenly develop a severe bend or curvature in your penis, especially after trauma, or if you experience sudden loss of all erectile function, get evaluated promptly. If you notice neurologic symptoms, weakness, numbness, loss of bowel or bladder control, that could indicate a spinal issue and needs urgent assessment. If your blood pressure is dangerously high, over 180/120, especially with headache, chest pain, or vision changes, seek immediate care. Let me tie this all together. Erectile dysfunction after 50 is not inevitable. It's not a natural part of aging that you just have to accept. It's a signal. A message from your body that your vascular health, your metabolic health, or your hormonal health needs attention. The men who maintain strong, reliable erections into their 70s and 80s are the ones who've protected their endwalls through lifelong healthy habits, or the ones who've aggressively addressed risk factors when they appeared. You can't change your genetics, and you can't erase decades of poor habits overnight, but you can start today. You can move your body, you can eat real food, you can sleep, you can manage stress, you can quit smoking, you can moderate alcohol, you can lose weight, you can treat your blood pressure, your cholesterol, your blood sugar. You can optimize your testosterone if it's low. You can use medications when needed. You can explore devices and procedures if first-line treatments aren't enough. And you can communicate openly, reframe intimacy, and break the shame cycle that keeps so many men suffering in silence. Robert, the patient I mentioned at the beginning, made changes. He started walking every morning. He cut out most of his evening alcohol. He worked with a dietitian and lost 20 pounds over 6 months. His blood pressure came down. His prediabetes reversed. His testosterone, which had been in the low normal range, climbed back up. We started him on tadalafil, 5 milligrams daily, and within a few weeks, his erections were firm and reliable again. More importantly, he stopped dreading intimacy. He reconnected with his wife. He realized that his erection problem was never the end of the story. It was the beginning of a larger conversation about his health. And addressing it made him feel younger, stronger, and more alive. That's what's possible when you take this seriously. I want to hear from you. Drop a comment with one action you're going to start today. Maybe it's scheduling labs, maybe it's going for a walk, maybe it's having an honest conversation with your partner. Whatever it is, commit to it. and subscribe to this channel because I put out weekly content on men's health, sexual health, prostate issues, testosterone, cardiovascular risk, all the things that matter as you age. Share this video with a friend who needs to hear it. Let's end the stigma and get men the information they need to live fully at every age.